All right, so let's see now atherosclerosis, vasculitis, and aneurysms. All right, so atherosclerosis is a type of arteriosclerosis, which is in general, this word means a hardening of the arteries that normally are elastic so they can store the energy of the pumping heart. In the case of atherosclerosis, a lesion forms in the inner layer of the intima of the vessel wall, right? Most important elastic arteries are the aorta and its branches. You already know those branches, the main ones. Okay, the coronary arteries, they branch out, are the first arteries to branch out from the aorta, and they supply the heart itself, and there are other larger vessels supplying the brain, as you can see in this diagram. Atherosclerosis develops slowly and without any clinical manifestation for as long as 40 years, for instance. So the patient is not aware of the problem and does not make any effort to control the modifiable risk factors, those that can be changed, like the diet, sedentarism, or hypertension. The problems the patient is exposed to are life threatening here, like ischemic cardiopathy, stroke, or venous insufficiency due to damage to the veins. As you can see in this graphic depicting the total death due to atherosclerosis in Spain from 2005 to 2017, the disease decreased quite a lot in the first years, probably due to two factors. One are the actions of the National Health Service that made an effort to lower blood lipid levels through the advice of proper diet, exercise, and with the help of statins. And on the other hand, we have the awareness of the public about this silent killer. From 2014, the number of cases is steady, as you see. We don't know all the underlying causes why some people develop atherosclerosis and others don't, but several risk factors have been identified, being the most dangerous hypercholesterolemia that we just checked in the previous lecture. When checking risk factors, always remember to differentiate those that can be modified than those that can't be modified. Besides high LDLs and low HDLs, have in mind that diabetes and inflammation are very important factors. So you know that C-reactive protein denotes that inflammation is present somewhere in the body. Cardiologist, this guy, your cardiologist, we will listen to in the seminar, gives outstanding importance to the inflammation in relation with the coronary heart disease. As it is logical, the clinical manifestations of atherosclerosis will depend in how badly a vessel is affected and what tissue or organ that vessel is supplying. The atherosclerotic plaques may narrow a vessel slowly and produce ischemia that is felt when more blood is demanded. But if the plaque breaks, a sudden obstruction may happen. Then when the plaque breaks, the endothelium is damaged and platelets will build a thrombus that further obstructs the vessel. If the thrombus detaches, it becomes an embolus that will travel until getting stuck in the vessel and causing an infarct. This is what happens, for instance, in strokes. An embolus gets stuck in a tiny vessel in the brain. Also, the damage of the wall of the vessel may lead to aneurysms, which is that affection of the wall of the vessel that may break totally. And if that happens, it's very dangerous because then you have an hemorrhage. But we'll see this a bit later. This map shows how atherosclerosis develops, starting with the risk factors and an increased tendency to arterial endothelial damage, which you can see in the green boxes. The resulting endothelial injury starts a chronic inflammation process responsible for endothelial dysfunction, which has three outcomes: increased permeability, that you can see in the yellow boxes, increased leukocyte adhesion, which is in orange, and increased platelet adhesion, which is in light green. Yellow boxes show that due to increased permeability, oxidized LDLs deposit in the vessel wall and trigger inflammation that contributes to the formation of a fibroatheroma. Light green boxes show how the injured endothelium also triggers platelet adhesion that contributes to the formation of the atheroma. In this image, you can see the evolution in time of endothelial dysfunction and how an atheroma first and a fibroatheroma grow in a vessel wall. We will briefly review now two more conditions involving blood vessels. The first one is vasculitis. Although the mechanism of vasculitis is not known, available evidence seems to point to an infection or defective immune response that triggers an inflammatory process that damages the vessel wall. If such damage affects the vasa vasorum, that is the small capillaries that nourish the wall of the vessels, necrosis of that wall will result. Vasculitis may also be the outcome of diseases like lupus that we reviewed just recently. In that case, we talk about secondary vasculitis, secondary to lupus, right? Vasculitis may affect any type of vessel anywhere, so any organ or tissue may be affected, causing a wide span of conditions. Besides that, fever, myalgia, arthralgia, malaise are some of the general clinical manifestations that can be present with vasculitis. All right, so let's go with aneurysm, which is the second vessel's condition we will briefly go through. An aneurysm occurs when an artery's wall weakens and causes an abnormally large bulge. This bulge can rupture and cause internal bleeding. The exact cause of an aneurysm isn't clear. Certain factors contribute to the condition, we know that. It is quite common in the aorta, an artery which is directly exposed to the pressure that develops the heart when pumping. And then here we have that in a true aneurysm, the blood remains within the vascular compartment. The wall of the artery itself is intact, although affected by a dilation that perturbs the laminar flow of the blood. The change from laminar to turbulent flow further damages the endothelium and more probabilities of breaking the wall. In a pseudo aneurysm, there is dissection of the inner wall and an hematoma forms. In this case, only the outer layer of the artery is preventing an hemorrhage. So the wall gets damaged from the beginning. There are different types of aneurysms, as you see here. Berry, fusiform, and saccular types are classified as true aneurysms, while dissecting aneurysm is a pseudo aneurysm. While the first three are dilations of the wall of the arteries, the fourth one is a severe affection of the wall of the artery. If that wall breaks completely, it causes death really fast due to a massive internal hemorrhage. Okay, if you think of if this is happening in the aorta, the one you see in the picture, you know that the aorta, this abdominal aorta, pumps many liters per minute, so there is no time for really anything. Two of the most contributing factors to the development of an aneurysm are atherosclerosis and hypertension. Hypertension we will review probably next week. Although these two factors may be independent, quite often they are related in the sense that atherosclerosis extended in time will finish by producing hypertension. Both of these conditions can be modified by lifestyle changes or drug therapy. Aneurysms are quite difficult to diagnose based on the symptoms because those can be very variable or not present at all until the vessel breaks, which puts the patient at a life-threatening situation. Imagine you see a male patient older than 60, heavy smoker, obese, following a bad diet with a blood pressure of 160 and 110 minimum, family history of heart or vascular problems, that complains of a sudden back pain, which is not associated to any other causes like trauma or whatever. You need to take this patient as a red flag because all of those risk factors. So it could be a good idea to refer him to a doctor that will probably prescribe a CT scan or ultrasound. Okay? Because aneurysms, they cause back pain. Alright, so like with any other condition, those risk factors that can be changed must be corrected, right? So this requires the collaboration of the patient, and to get the patient collaboration, it is essential to provide him or her with detailed information on the disease and the prognosis, the possible consequences. In the most severe conditions, surgery to insert an endovascular stent graft may be necessary. You see it here in the picture. It's a device that is placed inside of the, in this case, the descending aorta. Okay, and then it protects the wall of the aorta so it doesn't break. All right, so very well. This is all for this lecture. Thank you very much.